Hey guys, it's Sarah here. In this video, I'm going to be going over dermatology. So this is all you have to know in this category for the NP board review. And before I get started, I just want to let you know that all this is available in a PDF form. You can look in the comment section below and click on the link. So let's get started. So here are just some terms to differentiate all the different rashes. You have your flat rashes and you have your elevated rashes. You have your flat rashes. So in terms of the flat rashes, you have your macule and you have your patch. The macule is less than a centimeter and the patch is more than a centimeter. Just think of like flat, like a freckle, flat. They both start with F. And then we go on to elevated rashes. Elevated, so it's elevated, so you could palpate it. You have your papules and your plaque. The papules are less than a centimeter and the plaques are more than a centimeter. In terms of the papules, you have, for example, pimple could be papule because they're generally elevated more than a centimeter. And under this goes the vesicles. So vesicles just means that there's fluid in it, like herpes. You have your wheal, which is transient vesicle. You have your bulla, which is if it's a large vesicle. And you have your pustule, which as the name says, if it has pus in it. So the fluid could be anything, but if it's pus, then it's a pustule. And then the plaque, like we said before, is elevated more than a centimeter, for instance, psoriasis. So here are just terms you have to know. I'm going to go through it really quickly, and then we're going to start with the conditions. So annular just means that it's ring shape. Flexor by the skin on top of the joints. Intertrigo is basically it's where the skin rubs against each other. So like under the breast or someone really obese, the skin rubs against each other and a lot of bacteria and fungus could grow there. Keloid is an overgrowth of the scar tissue. Lichenification is where the epidermis thickens from chronic itching, so you keep itching it and you have really thick skin. Macular papular rash is a red rash with small bumps that are slightly raised. It's usually from a virus, very common in kids. Nevi is mole. Nummular is coin-shaped rash. Purpura is when bleeding is into the skin. Scales is when it's flaky, so you're going to see like flaky skin, like in psoriasis. So it's ulceration, which is full thickness loss of skin, for instance, a pressure ulcer. Verrucous is wart-like, and xerosis is dry skin. And the reason you have to know this is because in the question, they'll come up with these terms, and if you don't know this, those are key terms to differentiate different rashes and different conditions. So on this slide, we're going to be going over all the dermatology conditions that are dangerous, meaning that you have to refer right away or send to the emergency room before it progresses to cancer or before it progresses to life-threatening, even death. So number one is anaphylaxis, and the reason why it's under dermatology condition is because they break out in a hive usually. Anaphylaxis is a hypersensitivity reaction, usually caused by food, medication, bites, stuff that people are allergic to. Symptoms, like we said before, hives, angioedema, shortness of breath, they could start wheezing, they'll be tachycardic. You want to give them epi, IM, in the mid-outer thigh, and you want to repeat that every 5 to 15 minutes, and send them to the ED. Hives are under this also. Hives don't necessarily have to be anaphylactic, so if there's no anaphylaxis going on, so no shortness of breath, no angioedema, just hives, then it's not urgent and it wouldn't be under the danger dermatology conditions. If it was hives, then you would just self-limiting, remove the cause of why they're breaking out in hives and give them antihistamines. So let's go back to the danger dermatology conditions. So the next one is Rocky Mountain spotty fever. And this is a tick-related disease. They're going to have symptoms like flu-like symptoms, and it's usually going to occur in the spring or summer time. And the reason why it's under dermatology is because they're also going to break out in a rash. And the rash is going to be petechia, usually on the wrist and ankles. And you have to know the key terms like wrist and ankle. So if someone says petechia rash on the wrist and ankles, you want to think of Rocky Mountain spotty fever. So over here you see on the top right side, there's a picture of the petechia rash. It usually comes after day 5 or 4 after the flu-like symptoms. There's a huge high mortality for this, and you have to treat it right away. It's usually treated with doxycycline. So for tick-borne illnesses, we do doxycycline. The next danger dermatology condition is brown spider bite. So that's usually in the Midwest or Southeast of the US. So basically what happens here is that the patient gets a bite. There's no pain, just feels like a little prick. They go on with their day, but then the area gets swollen, blisters, red within like a day or two. The middle of the bite then becomes necrotic, as you see in this picture, and then there's an ulcer that takes a few weeks to heal. The treatment is you're going to clean the site, analgesics for pain, and tetanus shot prophylactically. Erythema migrans is a rash, but it's seen in early Lyme disease. Whenever you see this bullseye rash, as you see in this left picture on the lower side, you always want to think of Lyme disease. It's just going to appear anytime between day 1 after tick bite or a month after tick bite. It's like bullseye rash, like I said, or target lesion, however you want to remember it. And for this, you want to remember the words central clearance. It's commonly near like the skin folds, and they could also come out with like flu-like symptoms. In terms of the treatment for this, you are going to treat them with doxycycline, because like I said before, that all tick-borne illnesses are treated with doxycycline. The next danger dermatology condition that you're going to find is meningeal eczema. And what this is that it's a rare infection caused by the gram-negative bacteria that causes meningitis. Symptoms, you're going to have meningitis symptoms, so severe headache, neck stiffness, sensitivity to light, all that. And they're also going to have a sudden onset of high fever. But what they're also going to have is a hemorrhagic rash. And the hemorrhagic rash, you should know this part, does not become pale despite pressure. So if you put pressure on it, it won't lighten. There's actually a vaccination against this, but if it does occur, you want to refer them immediately to the ED, for the lumbar puncture, that whole thing. And for this is droppable precautions, meningitis. And over here on the top left upper quadrant, you could see over here the hemorrhagic rash. And last but not least, what we're going to be discussing on this slide is herpes zoster ophthalmicus. And this is a reactivation of the shingles virus in the ophthalmic branch of the trigeminal nerve. Symptoms are going to have vesicular rashes, like a lot of them, but it's going to be on the ophthalmic nerve. So think of your forehead and your scalp. They're also going to have a vesicular rash on the tip of their nose. So that's very specific. So when those signs come up, like a vesicular rash on the tip of the nose or on the forehead, scalp area, you want to think of herpes zoster ophthalmicus. You want to refer them immediately to the emergency room or the ophthalmologist, like right away, because it could affect the sight in the eyes. Okay, so here's our last slide of danger dermatology conditions. So these are, like I said before, conditions that you should refer right away, need to be treated right away. So melanoma. Melanoma, as we see over here, is pretty distinct. You want to do your ABCDEs. Asymmetry, border irregularity, color variation, like we see over here. It's black, diameter is going to be more than 0.5 centimeters, evolving, etc. Like a black, brown, and it's so irregular, and that immediately referral to dermatology for a biopsy. The next one we're going to go over is basal cell carcinoma on the top right. That's also cancer, but it has a low metastatic. So it's not like the melanoma that is very deadly, but it's still a skin cancer. So causes from that is chronic sun exposure. The symptoms, these are very specific to this. It's going to be pearly, as we see in the picture over here, white, pink, or brown color. That's going to look a little waxy, and it's going to have an ulceration in the middle, as we see over here. It does not heal, obviously, because it's a cancer. It's most commonly found on the face and head, because just think about it, if it's caused from sun exposure, those are the sun-exposed area, and like all cancers, you want to refer them to dermatology for a biopsy. Next, we go on to our subuncal hematoma. And hematoma, like always, is a collection of blood, and as we see in this picture, it's under the fingernail. It needs to be drained, so it needs a trephination. The next one we're going to be talking about on the slide is Stevens-Johnson syndrome, or toxic epidermal necrolytis. And this is a severe, very severe skin reaction to medications, usually medications like sulfonamides, some NSAIDs, allopurinol, and they break out. It's very distinct rash. They're also going to have fever, flu-like symptoms, and the skin lesions are going to be like vesicular, bulla on it, like in this picture. After they break out in that rash, the skin is going to slot. In really severe cases, the skin can even come off the patient and like detach, and the patient hemodynamically unstable. If you suspect this, immediately to the emergency room. The last one on this slide is actinic keratosis. Actinic keratosis is also caused from chronic sun exposure, and it's going to be rough, scaly patches, as we see in the picture. They can be various colors, like white or pink, and they're usually, like the other one, on areas that are most exposed to sun, so think of your face. They do not heal because it's a cancer, and if left untreated, it could lead to squamous cell carcinoma. So that's why you want immediate referral to dermatology for a biopsy. So now we go on to benign skin lesions. So these are the total opposite of the danger ones. For all these, you don't need to do anything for them. You should do yearly skin exams for them, but you don't even need to refer them to dermatology. Unless it's bothering them and they want it removed for some reason, then you would do a referral to dermatologists. So let's get started. So the first one is dermatosis papulosis, and like we see over here, it's small, blackish, really dark brown, I guess you would say. They're found on the face and neck, and they're most common in African American or Asians. And like we said before, they're benign, so no need to do anything. The next one is cholangioма, and this is made up of the blood vessels, as we see before, so they're very distinct. They're like bright red or even purple, but bright. And they're usually on the trunk of the patient. They do blanch, so remember, before the other ones do not blanch, these do blanch. So you can press down on them and they'll turn pale. And they're most common in adults over 40 years old. The next one is Cellulitis, and this is actually also over 40 years old, very common, which is why they're called age spots or even liver spots. They are pale usually or light brown, flat, oval spots. They're very distinct because they're brown, flat, and oval, and the borders are irregular and they're from the sun. The next one is Pacus hyperplasia, and this is, like the name says, hyperplasia, so it's an enlarged Pacus gland. What they appear as is small yellow bumps, usually on the forehead, cheeks, and usually over someone that's over 40 years old. The next one is seborrheic keratosis, and it looks like a wart, honestly, like a scaly, slightly raised wart. They're painless. The color is light tan to black, and they look like they're pasted on. So the boards like to ask pasted on, so think of that. The last one is a skin tag, and we all know what skin tags are. They're outgrowths of the skin. They're painless, and there's nothing to do unless they want it removed. Refer to dermatology. Okay, so now we're going to go through all the other skin conditions that are not danger and not like benign either. Candidiasis. What candidiasis is that it's a yeast infection. Risk factors for getting this is someone immunosuppressed, on antibiotics, steroid use, or honestly anything that promotes yeast growth. So think of someone obese with like the skin folds, diabetics, etc. So symptoms, it's going to be, if it's in the mouth, it's going to be white patches, as we see in this picture over here, usually on the tongue or the roof of the mouth. If it's on the skin, it's going to be bright red lesions, usually in the intertrigo area, like we said before, because that's when the skin rubs and bacteria and fungus could grow there. And then you'll have satellite lesions. And if it's in the vaginal area, it looks like cottage cheese. The treatment for this is good hygiene, medications. So since it's a fungal, you're going to give an antifungal, so nystatin, etc. If it's vaginal, clotrimazole. Next, we're going to go on to folliculitis. So folliculitis is an infection of the hair follicles. Under this, we have the furnicles and the carbuncles. And the reason for this is as follows. When the infection of the hair follicle, so we see this small little picture over here of the folliculitis, when it spreads deeper and there's pus in it, it's known as furunicle. So you see over here, the next picture going to the right has a little pus in it, so that's furunicle. When it's a cluster of them, so you see over here the carbuncle, it's bigger and it's a cluster of them, that's called the carbuncle. Risk factors are razor use, poor hygiene, breaking the skin, diabetic, etc. So if it's a folliculitis, you want to do a warm compress for them. Obviously, clean razor, wash their hands. You could do topical antibiotic ointment like mupirocin. If it's a furunicle, then it's the same thing as the folliculitis, but if the abscess is more than 2 centimeters, then they'll probably need incision and drainage. You should know that if this is present over a joint, you always want to refer them to the emergency room for an x-ray because you want to rule out osteomyelitis. The next one, carbonicle, treatment for that is, well, first of all, you want to get a culture and sensitivity. If it's not purulent, doxycycline. If you suspect MRSA, then Bactrim and Doxy. If they're immunosuppressed or you suspect that toxic or something, send them to emergency room. Okay, so here we go on to contact dermatitis and ectopic dermatitis, which is eczema. So I hit it in this chart so you can see the difference. So the causes for contact dermatitis is an inflammatory skin condition that is from exposure to a skin irritant or an allergen. Ectopic dermatitis, on the other hand, is a chronic inflammatory skin disorder. Symptoms, so contact dermatitis is red, itchy, and could develop into bullous or vesicular lesions. Ectopic dermatitis, first red and itchy, dry small vesicles, and then it ruptures into crusty yellow. That's the key term, crusty yellow. Just think of eczema. With eczema, it's common to be excoriated and thick because they keep scratching on it. Is usually found. So in terms of contact dermatitis, it's usually found whatever the irritant is. So for instance, if it's a necklace that's irritating them, the copper or something, then you usually find the rash around there. And that's the key difference, that in terms of contact dermatitis, the rash is going to follow the shape of the irritant. In terms of eczema, so in kids, it's common in the face, neck, knees, and elbows, and in adults, it's common in the hands, neck, and decubital flexural folds. For treatment for contact dermatitis, so it's being caused by something, so you want to remove the irritant. You can moisturize it, frequent baths like oatmeal baths, topical corticosteroids if needed, and you can even refer for allergy testing. In terms of treatment for ectopic dermatitis, topical steroids like hydrocortisone 2.5% for mild and triamcinolone for moderate. If it's itching, you can give them oral antihistamines like Benadryl. Some other stuff to know about this is that for contact dermatitis, you always want to look at the jewelry, yard, occupation, maybe that's causing the irritant. Most common irritants are poison ivy, latex, nickel, etc. In terms of ectopic dermatitis, which is eczema, you also want to know that stress and environment could exacerbate it, and it's actually commonly associated with asthma and allergic rhinitis. So now we're going to go on to other conditions. Hand-foot-mouth disease is commonly called Kawasaki disease, and the reason for this is because it's caused by the Kawasaki virus. It's very common in young children, like really young children, like under 5. They're usually in daycare or in camps. Very highly contagious, and the symptoms they're going to be having is rash and lesions on their hands, their mouth, and their feet, which is why it's called hand-foot-mouth disease. The treatment for that is supportive because, like we said before, it's a virus, like Tylenol, etc. The next one we're going to be going on to is impetigo. Impetigo is very contagious also, and it's a superficial bacterial, usually like staph, so gram-positive, infection of the skin. It starts out as a rash, like a red, sore, itchy rash, and then it turns into vesicles, pustules, and then it crusts over. And the key term you're going to find is it's going to crust over into honey-colored scabs, as we see in this picture. It's very common on the mouth, the nose, and the treatment for this is going to be topical antibiotic ointment like mupirocin. And if there's a lot of lesions, then you give oral antibiotics. You should just know that they can only return to school after 48 to 72 hours after starting on the antibiotics. Complications for this that you should know is rheumatic fever and post-streptococcal glomerulonephritis. The next one is Pyraceraceous rosea, and this is very distinct because it's going to start out as a herald patch. So remember herald patch, which is a single oval usually, or round patch. And then after like 3 or 7 days after it first comes, then you're going to have small lesions around it. As we see in this picture, there's a huge oval lesion, a rash, and then you have small little ones. So that's the herald patch, and that's the small little lesions that come around it. So it's very distinct in that way. The cause is really unknown, but most commonly caused by a virus, and you could also have a headache, fatigue, aches, but it's usually asymptomatic other than the rash. Treatment is really nothing. If it's itchy, you could do corticosteroids, etc. Next we go on to psoriasis. Psoriasis is a chronic inflammatory skin disorder. It's associated with other comorbidities, and there's a lot of different subtypes. But the chronic plaque psoriasis is the most common one. The way you're going to differentiate this is by the silvery scale patches. Usually very dry, and usually on areas like the knee, the elbow, the scalp. There's a whole bunch of therapies that you could do for this, but it's really based on the comorbidities, the cost, the severity. Usually it's like topical corticosteroids for the mild cases, and usually the moderate or severe are biological, but that is all going to be prescribed by dermatologists if it is moderate or severe. Next we go on to scabies. Scabies is caused by the scabies mite. The main symptom over here you want to know is really itchy. Scabies is very itchy, just all over. They're going to have small red bumps. It's going to look like tiny little pimples, I guess you would say. And also one key differentiator is that a lot of times they like to say that it's interdigital. It's in between the digits of the fingers. It's usually spread by direct contact in very crowded areas, and for treatment, permethrin 5%, or if you want orally, then oral ivermectin. The next one is melasma. Melasma is basically hyperpigmentation. It's most commonly seen in pregnancy or after pregnancy, or if the patient is on oral contraceptive. It's a chronic condition, so the stains are permanent, unfortunately. Vitiligo is hypopigmentation. So melasma is hyperpigmentation. Vitiligo is the opposite, hypopigmentation. So you're going to see random white patches on the skin. They can get bigger over time, and they're usually associated with autoimmune disorders. This you want to know for this, or actually really any other condition also, but this one specifically, it's associated with a poor body image. So you want to watch out for that and help them if they need a referral. And for this, you want to refer to dermatology for treatment. The next one is lipoma. So for lipoma, what it is it's a benign tumor made up of fat cells. It's painless, and it's very, very, very slow growing and asymptomatic. There's no treatment necessary, but you do want to follow them, make sure it's not growing much. What you're going to feel is like it's usually 1 to 2 centimeters. It's going to feel like a little bump under the dermis, and it's going to be round, and you can move it. It's movable. Like I said before, no treatment necessary unless it's irritating them or it's large. Next one is Xanthosis nigricans. Is basically hyperpigmentation, but it's like velvety hyperpigmentation. As we see in this picture over here, what you want to know for this is that it's associated with endocrine, so diabetes or metabolic disorders, or even malignancies. Most common cause is obesity and insulin resistant. Now we're going to compare the two types of acne, acne rosacea and acne vulgaris. Acne rosacea is also called rosacea. Acne vulgaris is also called acne, like the acne that you commonly see on your skin. They're both caused by chronic inflammatory disorders. The pathology behind them is acne rosacea is flushing and dilation of the blood vessel, and acne vulgaris is an overproduction of oil in the sebaceous glands. So basically bacteria clogs there, causes the acne. Risk factors for acne rosacea are menopause, medication, stress, heat, cold, etc. Risk factors for acne vulgaris is your adolescence, skin irritations, like stuff that are very oily like makeup. Medications could cause it, or hot weather when you're sweating. Symptoms for the acne rosacea, they're going to be papules, pustules, redness, acne vulgaris, you're going to have black and white little heads. Acne rosacea is most commonly seen in the middle of the face, and acne vulgaris is just all over the face. People even have it on their back or anything like that. You want to get a good H&P, if it's painful, is there discharge, a medication history, heat and cold, do they have their period, are they moisturizing, etc. For treatment for acne rosacea, you want to avoid sunlight, you want to wash your face, you can use medications like metronidazole or oral antibiotics. Do not use topical steroids for this, and you want to follow up with them. If there's no improvement, like for everything, you could always refer them to dermatology. For acne vulgaris, you want to properly clean, mild soaps, decrease the stress, because that could also be a risk factor for acne. If it's mild, you could do topical benzoyl peroxide. If it's moderate, you could do topical but also oral antibiotics like tetracycline, even contraceptives you could use. If it's really severe, you always want to refer them to a dermatology because they could prescribe stuff like isotretinoin, which you do not want to do. And if they're on there, make sure they have, their forms of birth control, etc. Okay, in this slide, we're going to be comparing and contrasting cellulitis and erysipelas. Cellulitis is an infection of the lower dermis and subcutaneous tissues, as opposed to erysipelas is a superficial form of cellulitis, but it affects the upper dermis and extends to the superficial cutaneous lymphatics. Causes of cellulitis is bacteria breaking through the skin and entering. For instance, skin trauma, eczema, there's an ulcer there, and bacteria gets in and enters and causes both of them, the cellulitis and the erysipelas. But cellulitis in specific is more commonly caused by Staph aureus, and erysipelas is more commonly caused by Streptococcus. Symptoms of both of them is going to be like pink, red, warm to the touch, thickened edematous. The difference between them both is that cellulitis, the lesions are generalized and they're not well-defined margins, and they could have pus in it. In erysipelas, the lesions are localized and have a clear, demarcated boundary and non-purulent. So you want to know those differences. Those are the key differences. With erysipelas, patients could be febrile and tachycardic, but they could also be with cellulitis. Treatment, it could be clindamycin, etc. If it's MRSA, doxycycline, or Bactrim. If it's severe, you want to give IV antibiotics, and if it's purulent, you might need to do an incision and drainage. Other stuff to know about cellulitis in general is that if the patients are having systemic fevers, not responding to treatment within a few days, spreading very quickly, or someone at risk like immunocompromised, you want to send them into the emergency room for treatment. You could also have BOLA or golden yellow crust, like indicating Staph aureus, which is the same one that we see in impetigo. There are two forms, you have your purulent and your non-purulent. Okay, now we're going to go on to 4 more conditions, and number 1 we're going to be talking about is necrotizing fasciitis. That is the bottom right corner in the picture over there. What this is that it's infection of the deep soft tissue. So what it does is that it leads to destruction of the muscle fascia and the subcutaneous fat near the muscle fascia. Causes, same cause, from bacteria entering the skin. Symptoms you're going to see is a red or purple edema that's going to rapidly increase in size. It's going to be very painful. You're going to have systemic symptoms, and they could even have Ebola. Treatment, you're going to send to the emergency room for surgical exploitation and debridement of the necrotic tissue. And obviously, they're going to be giving them antibiotics. Next one, in the top upper right corner, is going to be varicella zoster. Varicella zoster is chickenpox. Symptoms of chickenpox, besides for your fever, sore throat, you also could have, after that 24 hours, you're going to start getting itchy vesicular lesions. And the key over here is that they're going to be in different stages of healing. So we see in the picture, they're all like, some of them are bigger, some of them are smaller, they're all different stages of healing. That's going to usually occur over 5 days and start on the head, and it's going to spread all to the body. It's very contagious, and it's contagious until the lesions crust over, which usually is like 2 weeks. Varicella zoster, which is chickenpox, is going to stay dormant in the body. When it gets reactivated, it's called herpes zoster. So herpes zoster also causes shingles. It's in the left upper corner. You're going to see a picture of that. And the key for that is going to be on a single dermatome. So it's usually going to be like unilateral, and it's going to follow the dermatome shape. It is very, very, very painful, and it can even be painful before the rash even comes out at that site. Treatment is a cyclovir, and you want to start it as soon as possible. The next one is herpes wiltro, and that is a viral infection of the finger. And in the picture over there, there's a finger, and the causes are from HSV. So let's just say someone touches a cold sore or herpes. Think of like a toddler sucking their thumb or a dentist touching a patient's mouth. It's usually going to be on the tip of the finger, like on the side tip of the finger. Symptoms are going to have burning pain, blistering, bumps, I guess you would say, on the side of the finger. It's self-limiting, so symptomatic relief. If it's really severe, then you could do a cyclovir, but you want to cover it with a bandage until it heals so it doesn't spread. Now we go on to fungal infections. Anytime it's tinea, it's fungal infections. You have all different types. If it's barbae, that's beard. Capitis is the head. Corbutus is the body. Crurus is the groin, so think of your jacket. And pedias is the foot. In terms of tinea, they're all treated by topical antifungal, like the azoles, but tinea capitis, the one in the head, specifically is oral antifungal, so terbinafine, etc. Tinea vesicolor is also a fungal rash, and symptoms over here are going to be hypopigmentation. So you're going to see the white spots over there, most commonly in tropical climate areas, and it is not contagious. It's going to be diagnosed through potassium hydroxide preparation, and the treatment is going to be your topical azole antifungals like ketanazole or topical selenium sulfide, etc. You want to advise the patient that it could actually take like several months to fill in. So even if they take the medication for 5 days, it's not going to cure everything in a day. The last fungal infection that we're going to be discussing is onychomycosis. And this is an infection of the nail. As you see over here in the picture, there's a yellow discoloration under the nail, like yellowish brownish, most commonly caused by fungus, but could also be yeast or mold. Usually it's located in the great big toe, and you're going to do a fungal culture, KOH preparations, and the treatment is going to be oral antifungals like terbinafine. Okay, we're almost done. Now we're going to be discussing the bites. So in terms of bites, the problem with the bites is that there's a break in skin and there's a risk for infection. So normal symptoms of bites is going to be red, swollen, pain at the site. That's normal. Signs of infection from a bite is going to be fever, pus, red streaks, etc. Animal bites, you want to think of rabies because there's a risk of rabies, and a lot of times we don't know the animal status of immunizations. But you do want to get a good H&P, like what the animal tetanus status is, prior rabies immunizations, etc. In terms of human bites, so human bites are actually very, very dirty. And the one thing you want to watch out for human bites is the closed fist injury. So a closed fist injury is when, like this hits the teeth. And they're highly, highly prone for infection. If it's a closed fist injury, you always want to refer them to the emergency room or urgent care because they need an x-ray of the joints to see foreign body, rule out osteomyelitis. Treatment for both of them is going to be, number one, if there's bleeding, you want to control the bleeding. You want to wash the wound out with normal saline. You never want to suture or close a wound that has high risk of infection, like cap puncture wounds, anything deep, anything that was open, like a wound open for more than 12 hours. You never want to close them. You want to leave them open. In terms of medication, if it's a deep wound, you give them prophylactic antibiotics. If it's infected, obviously you give them antibiotics. Usually the antibiotics of choice is amoxicillin, carbonate. You obviously want to give them tetanus prophylactically, rabies, immunoglobulin, and vaccinations. If you're ever unsure, you could call the local health department. And one more thing, for cartilage damage, you always want to refer them to plastic surgery. Okay, next we go on to burns. So before I start with a different type of burns, you always want to refer to a burn center if it's third-degree burns, second-degree burns that are more than 10 total body surface area, all electric burns, lightning burns, or any burn that's on the face, genitalia area, feet, or major joints. Always immediate referral to a burn center. Now in terms of burns, you have your first degree burn, which could be like a sunburn. They're superficial thickness burn. They're red and painful. Treatment is going to be water, cold pack. If the skin's open, you could do topical antibiotics and aloe vera gel to cool down. Your second degree burns are the partial thickness burn. The difference between this is that it has blisters. So it's also red and painful, but with blisters. With this, you can use a silver sulfadazine cream. You never want to do it on a face because it could stain. You could do topical antibiotics, you could do dressing, water, soap, etc. Your third degree burn, you're not even going to be dealing with because you're going to automatically refer them to right away to the burn center. Always with third degree burns, you want to worry about your airway. Third degree burns are going to be painless, and with that, the entire skin is usually destroyed. So with burns, you want to calculate total body surface area, and that's going to be doing by the rule of 9. You add up all the percentage. So for instance, in adult, you get 9% for the arm, 9% for the head, 18% for each leg, and 18% for the front of the trunk, 18% for the back of the trunk. And basically you add them up and you see what percentage of total body surface area, which is basically an estimate of the extent of the burn. Okay, next we're going to go on to bioterrorism. Not really that much. I'm just going to really quickly just say a few stuff about it. Anthrax, there's three types. You have cutaneous, inhalation, alimentary tract. Cutaneous is the most common type, and it's usually caused by working with animals, wool, or bioterrorism. With cutaneous anthrax, you could see small, painless, itchy papules. They enlarge and leave a necrotic black ulcer and edema of the surrounding around the black ulcer. For this, you always want to notify the State Department, doxycycline, and there's honestly a really high mortality rate without treatment, so you always want to give prophylactic post-exposure of doxycycline. Smallpox is caused by the variola virus. Symptoms of that, they're going to have sudden onset high fever, flu-like symptoms, but they're also going to have a vesicular or pustule rash. It's usually going to start in the mouth, spread to the face, go to the arms and the legs, and there's actually a vaccination against it, so there's also a vaccination for post-exposure. Okay, last but not least, what we're going to be discussing is wounds. You have your phases of wounds. Hemostasis is the first phase of wound healing. So you have the bleeding, so you have the blood vessel constricts, platelets aggregate, so they're going to trigger the clotting cascade, and it's all is going to be to form a clot. Then we go into inflammation. You're going to have the increased vascular recruitment. You're going to have all the cells come in. You have the macrophages, the lymphocytes, the cytokines. They're all going to come. And then we're going to go on to the proliferation phase, is the basal cell proliferation and epithelial cell migration. Then we have the remodeling phase, which is basically the wound closes, the collagen comes, repigmentation, and a scar could form also. Other wound information that you should know, you always want to give tetanus prophylactic. If they got it more than 5 years ago, give them a booster. Never close infected wounds by something more than 12 hours old. Wounds that are cosmetically a problem, like think of your face wounds, referral to plastic surgeon. And if you cannot remove the foreign object, you always want to refer them to emergency room or get an x-ray. With all the wounds, you always want to check the distal pulses, range of motion, sensation, foreign objects, etc. And usually sutures are removed between 7 to 10 days, like around 5 to 7 days for face and around 7 to 14 days for extremities, depending on the wound and how you closed it. So thank you for watching. That's everything you have to know for dermatology. Please like, subscribe, and stay tuned for more.